all, I'm your host, Kelly Nagel, and today I had the pleasure of talking with Dr. John Essien. John's a health economist in the UK, but his experience spans the healthcare industry, from clinical practice to fieldwork, public health, health finance, research, and policy design. John followed his curiosity about biology and difficult personal experiences into medicine. He began his career practicing in Nigeria. However, after realizing the futility of trying to overcome poverty with medicine, John pursued a degree in health economics. Today, John is working on designing and implementing strategies for sustainable health financing. In our conversation, John takes us on a journey to the intersection of medicine, economics, and policy. And he enlightens us on how health economists are a key part of addressing health equity. Enjoy. John, thank you so much for joining me this morning. Here's the Problem Podcast.
Thank you for having me.
Let's jump right in. Oh my gosh, I'm honored that you would take the time to join us.
Okay. I'm excited to be here as well.
Let's jump right in. Here's the problem. Health equity and healthcare policy are massive topics. You have experience over a broad spectrum of healthcare, medicine, policy, business. Currently, you're a health economist, but you're also a practicing physician. So let's start with your journey into medicine. Can you tell me a little bit about your background in both the medical and the healthcare industries?
My journey in medicine started out of, the interest in human beings and, just being intrigued in how human beings operated or worked, like from a biological perspective. I would say I remember sitting in a plant biology class. I can still remember what it was about. It was about phlegms and cambiums, like that's what it was about.
Two words I don't think we will ever hear on this podcast again.
Exactly, about how plants transport water and minerals like along the trunks of trees and leaves. And I remember sitting there thinking, if this is this interesting, then how much more interesting will it be studying how, this same things happen in human beings? And I think that was the very first spark for me, in the direction towards medicine, just the curiosity. And then this was around maybe 11, 12 years old. And then closer to the end of what we call secondary school, what you would call high school. When I was beginning to be more aware as a teenager. I grew up with my grandparents. And
in Nigeria, correct?
Yes, in Nigeria.
Nigeria.
And just before my secondary school graduation, I lost my grandmom. And I lost her to a long-standing ulcer on her leg, which, had deteriorated over time, didn't get the proper medical attention because of lack of knowledge and all of that, those type of influences. She went for the more traditional care, which was not successful, obviously. And then by the time they eventually opted for medical care, it was already too late. And so that curiosity coupled with, that loss, somebody very close. She was practically my mother because she raised me.
I'm so sorry.
It just drove me completely into medicine. And so I went to medical school, was successful, came out a doctor, and started. First year post-medical school is usually an internship year. And I was just completely knocked off. I didn't expect that. So went to internship, and it was very different from where I trained because I did my internship in the poorer part of the country. That's up north.
Okay.
That's where you hear of the insurgency, Boko Haram, all of that.
Yeah.
My internship was actually in the heart of one of the, biggest, or I would say biggest Boko Haram insurgency periods.
Oh, wow.
That was 2010 2015, 2014, 2015, 2016. And so I was exposed straight on to what poverty can do to a person's health. I felt like there was nothing I could do at the level of the hospital to help because, thinking back to my grandmom's story, we had so many of those types of cases where they were coming in when you literally could do nothing to help. All you could do is patch them up, cross your fingers, and hope, one survive. During medical school, I remember the first time we saw a case of malnutrition. At that time, we were doing pediatrics and obstetrics and gynecology. That's the women's health. And I remember the pediatrics professor stopping the rounds because we were going on a ward rounds. He literally stopped the rounds, asked for somebody to go and call all the other students in the other arm of the class that were doing obstetrics and gynecology to come see a case of malnutrition because in his sense, we may never see one again. So this was in the southern part of the country. It's a lot more, the education rates is higher. People are much more enlightened. Malnutrition is not that much of a problem, even though you would still see it. So to be able to have a good teaching moment, having seen one classical case, he had to stop the rounds, ask for the other members of the class from the other side that were doing something else to come over and see this one case because they may not see it again. And then contrast that to going up north, and every patient, I started in pediatrics. Every patient I saw came in with whatever they came in with classical malnutrition. Like it was the add-on. It was really bad. And I remember thinking, there's really not much you can do here. Like I just completely kind of got a little bit disillusioned with clinical medicine because it looked like we were just there with all these tools that we could not use. And then they would come in, and even with how bad they were, they couldn't afford the treatment. And that's when I started to, think broader in terms of what my aspirations and how I could contribute. Thinking more policy, more structural, more finance approaches towards healthcare. And going from there, I went on to work in a non-profit health organization that was focused on HIV, and then went on to work with the health financing company. We call them HMOs over here, health maintenance organizations. I think you have a lot of those in the US as well. Our health financing system is somewhat similar to that of the US. Okay. And then after that, I've still been doing a bit of clinical medicine on the side. It's like that, you can't,
you can't
really leave it. Yes, you can't really ever just leave it. And then I came over to the UK to do a master's in health economics. And since then, I've worked in policy, I've worked in more analytical health economics aspects. And I've also worked here in the UK in a more clinical role. So yeah, that's my story and how I've got here.
That is quite a journey.
Yes, it is.
So help me understand what health economics is and what does a health economist do? On the surface, it doesn't seem you have health and economy.
Yeah.
How does that work?
All right. So back home, I don't know if it's the same sentiment everywhere in the world, but back where I come from, that's Nigeria. When someone says he's an economist, the first thing that comes to your mind is, he's stingy. He doesn't want to let resources around. So, in a sense, that's right. That's in a sense what the economist does, but it's not necessarily because they're stingy. So, a health economist basically looks at healthcare and healthcare expenditure or available resources for healthcare, and says we have so many diseases and we have so many healthcare needs as a population, and for the resources we have, if we were to dedicate all the resources we had to treating all the diseases we had, giving everybody free treatment, we would still be in a deficit. And I mean literally every resource, because healthcare is such a condition that the more treatment you give a person, the more problems you cause. And I don't mean that in a sinister way. I mean that in a good way, actually. So take, for instance, the life expectancy across the Western countries, the developed countries. It's increased and it's nearing the hundreds now. And what that means is you have a lot more frail people with a lot more disease conditions that you would have to treat. And a lot of them are coming in with 2, 3, 4 disease conditions. To treat these disease conditions and keep them as healthy as possible, you would have to engage ever more sophisticated treatments, and these are ever more costs. So the more healthy or the longer you keep a person living, the more expenses you have to incur in continuing to keep them living. So what the health economist has to grapple with is coming in and saying, for the resources we have, and we have very, very limited resources allocated to health. For what we have to look at the best outcome that we can get for the limited resources we have. This would mean looking at how much are we hoping to spend on a particular healthcare, say medicine, an intervention, a public health project, and then saying how much benefit do we look to achieve from this in terms of lives gained or life loss we can avert, or in terms of healthy years gained, in terms of quality of life, and that's a very big one as well. How much of that can we get for the costs that we are, expending? And they have to balance that very finely with, human sentiment, because there's no price you can place on life. So it comes down to a very fine balance between saying, oh, I'm not going to give you XYZ $1 million because that's going to save only 2 people, to having to stare those 2 people in the face to say, I'm not going to give you the money because your life is worth less than to get. So it's a very, very delicate balance that the health economist has to thread rather. And that then goes on to feed the policy of the country in terms of the healthcare policy. So a health economist basically is someone who rationalizes the available resources in hopes to get the best healthcare outcome from those resources, but on the backdrop of, equity concerns, human sentiment, human life sentiment concerns, and, wrapping all of that in a bundle that at least everybody can come to some sort of, consensus with. So that was a long definition. I hope I managed to capture.
Yeah, that's a lot of responsibility on health economists. Where is your resources, I'll put best in quotes, best used, and not to dehumanize, but in a business sense, gaining the biggest return on investment.
Exactly.
And how does that work, with the economy? Because there's a financial component to this, and I would think if you were able to invest these resources in a place like northern Nigeria, or anywhere really where there's poverty and higher disease rates, that they could better contribute to society. And is that
Certainly.
a vehicle for more profitability and a better economy?
Certainly, but I mean, it's trickier with health. And I think for us health practitioners, this is an aspect we don't preach enough. The tricky thing with health is that even though research has shown, and there's copious amounts of research that has shown that healthcare is not only an investment in like that whose yields are lives and quality of life improvement, but the yields are also financial. Problem is to get the financial return on investing in health, you would be looking at years, or you would be looking at financial returns and that are not so tangible, that not that they're not tangible, but they're not easy to track. So for instance, if I treated a child of diarrhea and they spent another 12 years or say 20 years before becoming the MD of a Fortune 500 company, in those 20 years, there's no economic or financial metric that's in place to track them up to the point where that's useful to society. So all that information is lost. That's a loss to follow up financial information. Basically.
You can't put it on a spreadsheet and
you can't
put it on the news or use it in a political debate.
And then by the 20th year, everybody forgets that this one child had been saved from malaria, and it's just another day in the life of the child. And on the other hand, you bring someone back from the brink of, say, cancer, from death from cancer, and they go on to continue their normal lives and continue their normal, business or whatever it is they were engaged in. And what we tend to do is view that as, okay, they've gone back to work, they're productive, they're earning monies for themselves. But we don't sit back to say, if we didn't save this person, they would have been dead in 3 days, right? But now here they are 5 years later, still contributing positively. We just take it for granted that this person didn't die 5 years ago. So all the economic, inputs that they're putting into the society just, it's taken for granted. It's just, yes, he's alive, so this is what he should be doing. But in the real sense, the fact that they're not dead is the reason why they are, economically or financially productive. So we don't yet have the financial machinery or economic machinery to capture some of these more tangible financial gains that healthcare, puts out. That's why a lot of the times we think of healthcare returns on investment only in lives gained or, health quality of life gained, and that type of thinking. We are not yet equipped to think about these things in financial. It's not intrinsic. It's not something that comes naturally. You would have to step back to think about it that way, and I think that's kind of the problem.
Yeah, as you're saying this, I'm thinking the only association most people have between health and finance is just how expensive healthcare is and how it's putting millions, particularly of Americans, in debt. Is it we just don't have the structure, or did you say the machinery to identify the financial, the positive financial gains that a healthy society brings? And or is it just a mindset that needs public awareness for us to look at this differently?
I think it's both. I think it's both to a large extent, because to the second point, like I said, it's not something that comes to us intuitively. It just doesn't, you don't sit down and think, oh, if I didn't die yesterday, I wouldn't be making XYZ amount of money. Or if I wasn't sick yesterday, I would have, because I mean, it's not even death. It's economic days lost to not being at your best. In health economics, we will call them absenteeism or even presenteeism. So absenteeism is when you can't be at work because you're sick, and presenteeism is when you are at work but you're not, functioning 100% because you're ill. So to health economics credits or health economists credits, they've been designing frameworks to kind of capture this economic value that, care for health tends to bring to people. But it's not just the natural thing for people to think that way just yet. And maybe with more education, that will start to be a little more, out there. But for now, we're not there yet. And health economics as an a vocation is it's a fairly new one, so it's evolving as well, and they're also at the infancy of putting out the machinery to kind of understand some of these issues. So give it a few more years and I think it would be more out there in people's minds, the way we view health and healthcare financing and those types of considerations.
Amazing. So look for your name in Forbes or Time as the person who's solving the healthcare crisis. That's what you're
Hopefully.
saying. It's just a few years away.
Yeah, just a few years.
And then I'm going to say, I know John, he's on our podcast.
Hopefully.
So question for you. When you talk about health economics, I know you're in the UK right now. You're from Nigeria,
Yeah.
like different ends of the spectrum in terms of healthcare, depending where you are, probably in either country.
Yes.
When you talk about health economics, are you looking at a macro level across the globe where whatever policy suggestions you put in place could be a template for any country? Or do you really have to dig down to a micro level and customize it depending on global north versus global south, or like the north of a country like Nigeria versus the south of a country? Is it that granular?
Yes. The concepts are almost universal, but
Okay.
much like other economic concepts, you need to plug in the context specific metrics or factorials into the particular niche you're dealing with. And to that extent, if you're going to, or if you want to have a successful health economic analysis and make successful policies, then you have to go down to the nitty gritty. I'm taking, for instance, the health economic approaches that we use in developed countries as compared to the health economic approaches we use in non-developed countries. You would hear things like cost per quality. So in more developed countries, they use the metric, like I said, it's more or less a cost benefit analysis. So how much are we spending for how much gain? But now the gain is in health, life and quality of life. So in places like the US or the UK or the Western Hemisphere, you would hear things like cost per quality, which is cost per life gained and the quality of the life gained. But in more middle, low income countries, you will hear things like cost per daily averted. And that takes into account the differences in the epidemiology and the health expectancy of different diseases. So a DALI is a disability adjusted life year, which is almost opposite to what a quality is. So over here in the UK, if you're doing an analysis, a health economics analysis, you're looking at, for this amount of money I'm spending, how much life am I gaining and what is the quality of that life? But over in Nigeria, if you were doing an analysis, you would be thinking, how much debt am I averting? You see the difference now. So
yeah, I'm actually kind of
it takes you aback.
stunned.
Yes.
I mean, gosh, talk about equity. Wow.
Exactly.
Or inequity in this case. Jeez.
So that's actually stunning. So when you take into consideration big killers like malaria, you know that what you're dealing with, what's staring you in the face is the sheer number of children dying or people dying generally. So you're at that point, your goal is to cut down the number of deaths as much as you can.
Mm.
While over here with someone with a heart attack, you're thinking, how do I save this person and give him the best quality of life? So to the question you asked, that's how some of the peculiarities of the different spaces feed into the kind of analysis we make.
I'm literally emotional over here just thinking about, I mean, we know there's disparities in the world, but I don't know, it's something about like those fancy acronyms you just use and putting that into context of a person's life. Your host is speechless. I'm
It's
blown away. I'm the inequities of this world are not lost on me, but that hurt. Wow.
that's what health economists have to deal with. And I
Health
mean,
economists make people cry.
I'm sorry. I apologize on behalf of health
Ooh.
economists around the world.
Okay, so how, all right, let's talk about something a little more hopeful. How do you move forward? So you have these two different points of measurement: cost per quality, cost per deaths averted. How do you move forward? If you take all this good information, is there a plan forward just on paper that health economists can say, hey, this is how we can address health inequities and provide better quality of life? Or are there other legal, political, social factors that you have to contend with to create a better policy, healthcare system, better health equity, et cetera?
Certainly. With health economics, ingrained into the very fabric of health economics is the issue of equity, and it's really, really big in health economics. Um, as far as doing these analyses are concerned, you could do all the Excel sheet analysis you would like to do, plug in all the sophisticated software, analysis, and at the end of the day, however good your analysis was, would be an analysis on paper. And at the end of the day, you're dealing with real human beings.
Mm.
So there's no way you can escape the political, and sociocultural aspects of, healthcare, because you have to be nested within those dimensions. And what the health economist does is try as much as they can to find a way to plug these modules into the analysis. And then even at that, it's a piss poor job, because it's really difficult to model those kind of, those kind of not very tangible things like human emotion or cultural, say cultural things that we regard on a more cultural
Mm-hmm.
level. And all of these things are good indicators of, healthcare outcome. The data is out there, to say that to get the best healthcare outcome, religion is a very strong, point. Um,
Mm.
Cultural mores are very strong aspects, and it's really difficult to model all of this into, how do you model religion, for instance, or how do you
Yeah.
model someone's ethical, dispositions. But at the end of the day, what the health economist does is try as much as they can to get which the parts of these that they can into their models, but then it has to still be situated within the broader social, um, political context. And that is where the policy aspect comes in, and where the policy players have to sit down and say, this works for us, that doesn't work for us. We may need to look at higher costs or lower costs you know, with consideration of X or Y or Z, and that gives it a more robust, or at the end of the day, they can have a more robust policy, healthcare policy plan for whichever population it is for. But on the other hand, or the other side of it, is the equity aspect, and that they're very interesting equity dilemmas. For instance, um, do you want to treat kids, or do you want to treat 5 kids, or do you want to treat 170-year-olds? Those are not very easy questions to answer. You could one way or the other and say 5 kids would have cumulative of 150 years, and 170-year-olds, depending on the life expectancy of the population. It could be 20 years between the 70-year-olds. And so you have to balance some of those kind of equity concerns. How much healthcare are you going to deprive the richer people, to give a wider mass of poorer people healthcare? And all of that tends to need very delicate balancing. And part of that is what a health economist, and I mean, I was trained as a health economist and health policy analyst as well. So part of that are the kind of things that you need to balance in making healthcare funding decisions.
So I'm sort of envisioning that you or any health economist needs to go on to win the presidency or be a prime minister who can then make all those policy decisions, because you would understand all this. But I don't know of a lot of heads of state who have backgrounds in health economy. So short of that, is it feasible in the real world to have a health economist, an insurance company, and a government legislator all at the table putting this together?
I would say yes, and I would say it should be the ideal thing to do. Much more developed countries and even the developing countries are currently beginning to see the usefulness of having health economists on their teams. With the UK, for instance, NICE is the body that kind of helps them do some of these difficult decision making. So, for instance, every pharmaceutical company coming into the UK has to submit the evidence for their medications, cost effectiveness analysis, and NICE has to be the body that does the appraisal for that. So what they do is take your evidence, look at your evidence, look back at country data and look at where the healthcare needs are, look at the cost of, what your medication as a pharmaceutical company would cost the country, and then make the difficult decision of saying, well, the UK cannot fund this or can fund this based on the healthcare needs that we have. And I think it's a very difficult decision to make, but somebody has got to make that decision. And for the UK, NICE does that. I think for Canada, there's a body called the Canada HTA organization. Okay. Europe has Euroneta, and they do that for Europe as a group. For America, it's a little bit disintegrated because America's healthcare system it's a unified block. So there are different bodies that do that for America. But you have those set bodies that are doing that for most of the much more developed countries. In Africa, we don't have that yet. And to be fair, health economics is still a very, 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 in fact, it's still where health economics in the UK would be maybe 10 years old, health economics in Africa would still have been born maybe 3 days ago. So it's still in its infancy, but we're getting there to be on the optimistic side. We're getting there. We're seeing a lot of, health economists of African descent who are actively contributing to shaping the conversation on the continent. But we are yet to see structured bodies that are, responsible for the kind of things that NICE or CAT HTA would be doing for UK and Canada, respectively. But we're getting there, and I'm optimistic that in shorter than expected, we would have some of those bodies in place.
So two questions that come to mind on that. Do you find that though that sort of regulation deters pharmaceuticals from trying to work in those countries, or that those countries don't have access to the more sophisticated type of treatments because pharma doesn't want to go through that regulatory system, or doesn't want to be, and I'm assuming, so correct me if I'm wrong, doesn't want to be capped or told how they can or cannot run their business?
No, quite on the contrary, they cannot afford to do that.
Oh.
So, for instance, it's different in the US, and part of the reason, or at least in my sense, part of the reason why healthcare is really expensive is the US is the absence of these kinds of, regulatory bodies. The FDA, for instance, just regulate. It does some of what NICE does for the UK, which is things like scoping for new health, for new drugs or health technologies, and guiding them through the approval processes. But it stops there at the approval. NICE takes it a step further to say, even though your drug is approved, do we need it for our population? Is it something that's cost effective for our population, and can we afford it? So, and these pharmaceutical companies cannot operate solely in America. Obviously, they make the big bucks in America, but they can't survive only in America. So they have to make inroads into other parts of the world. And if they have to, they must go through these gatekeepers. And so Australia, Canada, which has, and you would notice that most of the countries that have these kinds of gatekeepers are countries that have universal health care, for the whole population. The UK has free healthcare for everybody. Canada has some sort of, part payment, but it's mostly free. Australia is a similar story, but and most of most of Europe has some structured universal healthcare system going on. And so with that, it's easier for the country to negotiate against the pharmaceutical companies. So for you to be able to bring in any medication into the country, you have to go through those bodies. And if you don't, then there's really nothing they can do for you.
Yeah, so, you lose the market.
Yeah, you lose the market. That way they're able to negotiate better, and they're able to, kind of set limits on what comes into the country, what doesn't, what is beneficial to the country in terms of financing, and what isn't. And so those are kind of the differences between, most of the other developed countries in America. In America, as long as FDA has approved it for that particular use, if somebody is willing to buy the drug at whatever price they want to buy it, it's an open market.
Yeah. So my second question, when you were talking about that, which makes me think about this even more from what you just said, could an answer be that more countries develop these regulatory bodies where it's like, all right, well, XYZ pharmaceutical can't get into the market because they don't want to cap their profits. We'll just go to next country that has an open market. But is it sort of peer pressure if all of Europe has regulatory body, Asia, Africa, then it's sort of like, safety in numbers, where pharmaceuticals have to then bow to that expectation that you cannot jack up your prices and put people in debt to give them health care. Is that reasonable?
It's an interesting question. From the perspective of pharmaceutical companies, and this is not to attempt to throw a shade at pharmaceutical companies, because they do an incredible job of keeping us alive. If the argument for from pharmaceutical companies is anything to go by, it goes this way: that America pays for the whole world's healthcare in some sense, because by being, the most open market, it allows pharmaceutical companies the legroom to do spend all the monies they need to spend in R&D,
Right.
and then
Innovation. Yeah.
innovation and all of that. And then off the back of that, countries like the UK, Canada can do their, one front negotiation. And then one would argue, if America was to go the way of all the other countries with the one block type of negotiating pharma prices for the country, how much hurt would that do to pharmaceutical companies? And I'm not very privy to the financials of pharmaceutical companies, so I can't, make the moral argument of, oh, they 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 are not making as much money as they claim, or they're making more money than they claim. So it's a tricky conversation to have, going by the argument that America pays for the healthcare, needs of these other countries that are not so, whose markets are not so free. But on the other hand, I think it's there's another point that is kind of buried in that conversation, and that's the point of overtreatment. Part of the work of a health economist is not just to um find the most cost-effective treatment. It's also to help, whoever is funding, or even the citizens, avoid overtreatment, because overtreatment on its own is a problem, not just financially, but also health-wise. And people are wont to get overtreated if the treatment is free. And the UK sees a lot of that as well. So part of that gatekeeping is in curtailing how much treatment people get. Because if it's free, then they're going to get it. They're going to get a CT for just bumping their head on the wall and having a little bruise, when that's not necessary. And so those are some of the dichotomies between, free markets where you have to pay, and you have to carry at the back of your mind that this is going to cost me. And so you're not accessing that healthcare as ravishly as you would have in a country where it was free. And then in the free country, where the country itself has to do the gatekeeping, but on the part of the citizens, it's a free-for-all, buffet, healthcare buffet. So it's not very
Not heard that
straightforward.
term. I love it.
It's not very straightforward. It's a delicate argument to have, but I guess we're going to see how it unfolds. We'll see how it unfolds with the policy progress that's unfolding in across the world generally. But at least that's what it is for now.
Awesome. So what's some of the work you're doing now in terms of research and building models? I know you're working with the UN. I'm sure you're doing a million other things as well, but what are some of the things you're working on to address this, to come to some sort of conclusion? How do we dispense healthcare equitably and at least in America's case, in some sort of affordable way?
Okay. I mean, America's case is really interesting. Unfortunately, I've not done much work in the American continent or subcontinent. Much of the work I've done is for and in Africa, and
all right, keep America out of it. We're our own
Yeah.
complex
I mean,
anomaly.
I could talk about America for the whole day because America is always on the news, and healthcare is a very, very big topic in America. So, I mean, we could have that conversation for the whole day. But in
Part two
terms of
of the
yeah,
episode.
in terms of work that I have like actually done, health economics work I have done, it's been in Africa. So recently, and I mean, before I jumped on the call, I was actually typing out a some sort of policy analysis of the data that we have gathered
Hmm,
so far. And so we're working on the cost of action and cost of inaction of funding some disease areas in Africa. So the idea was most of the funding going to Africa has been going to three major diseases:
okay.
HIV, um, TB, and malaria.
Okay.
But just below that, in terms of the number of deaths incurred from those diseases, are uh, childhood diseases like diarrheal disease and lower respiratory tract infection. And so what we've been doing is saying, so you can either neglect these diseases or you can fund their treatment, or even if not treatments, programs to prevention programs, whichever
Hmm.
it is. So, and both of them are going to cost you, basically. What we're saying is, which cost would you rather have? Would you rather bear the cost of not funding them, and then we've built a model to show you what it would cost you to not fund them? Or
Hmm.
would you rather fund them, and then we also show you what it will cost you to not to fund the strategies to curb these diseases? And then the data speaks for itself. So what we're doing is building the costing models and letting the data speak. So you
Hmm.
can see from a macroeconomic level and from a microeconomic level the cost of not doing anything. And you can see from the same perspectives the cost of doing something. And thankfully, from our data, the cost of doing something is much less than the cost of doing nothing. And
Excellent.
so both in terms of in financial terms and in life and quality of life terms. So that's something that's been exciting to see, and that's what I've been working on in the last few months.
Are you finding that policymakers and governments are receptive to that data and moved by it?
Um, luckily, this um this project is funded by the UN, and it is for rapid implementation across 7 countries in Africa. So
Wow.
I said luckily because it's not always that way. And that's not just, in African countries, it's a global problem where the the duration between policy analysis or economic analysis, policy analysis, policy recommendation, and then the actual, execution of that policy is is a very long duration. There's a long time gap between that. And the
Mm,
problem with that is that by the time countries then decide to enact the policies that was, that was come up with 3 4 years ago, the landscape has changed, and you've
yeah.
not factored into your new execution the changed landscape, and your execution becomes problematic, and it looks like the policy was not, reasonable. But it's
Mm.
just that the time gap between policy recommendation and execution, a lot has happened in that time. And that's been a big concern for health economists, for health policies. And it's something that people in the health space are looking to work on and try to see how that can be shifted. But it's a concern worldwide.
Has there had to be, and this might be a stupid question, there had, at least on the health economist side, has there had to be a major shift because of the pandemic? or has that sort of
Ooh.
kind of just gone by and not necessarily affected the work you're doing, at least with this UN project?
Generally, there's been a big shift. So I don't think there's anything that the pandemic has not affected.
Okay.
It's been a huge, 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 huge shift. So with the project, and I don't know to the extent that we are erroneous in that regard, but with the project, we had to make the conscious decision to turn a blind eye to the pandemic and act like the pandemic did not exist. Because
Hmm.
if we were to, factor in the pandemic, then it would have done a lot to the model. So we decided to look at lower respiratory tract infections that did not include, COVID-19, which is also a lower
Hmm.
respiratory tract infection. To be fair, it would probably have worked in our favor, or in the favor of what we were hoping would be the case, but then it wouldn't be the kind of data that would be it wouldn't be a how do I put this? It
We,
would be a skewed data in that sense, and we
yeah, be
didn't want any.
circumstantial, right?
Yeah, exactly. We didn't want anything circumstantial to skew the data that we were trying to present. We wanted to get as close to the actual reality as possible. And
Mm.
even though a one-off would have been in the favor of what we were trying to see, or what we were hoping would be the case, we go in there. I mean, you go into data analysis with a hope. Sometimes it's not what you hoped for, and you adjust your knowledge and understanding about what the landscape is. Sometimes it's what you were hoping for, and the data bears itself out. But you don't want to taint whatever you're doing with, you know, these kind of one-offs that then give a very, very skewed picture. And so that's
Mm.
why we did not include COVID-19. But
Mm.
the extent to which that was wrong or right, we can't really tell. This was just the logic we were going with. And so yeah, we had to just show up COVID-19 as an aside, just so we don't.
Wow.
Yeah.
Wow. We talk a lot about data integrity at the Teen Think Tank Project,
Yeah.
and following the data, not creating sort of
Exactly.
preconceived
Exactly.
notion, and then interpreting data and questioning those interpretations. Is
Mhm.
the quick blurb I'm getting on the news, about this data or stats, really telling the whole picture, or are we just kind of
Or we
taking it out
just
of context for
exactly,
something
exactly,
that we're going to
exactly,
apply to this because it sounds good? So I love
exactly.
your comments about, hoping for an outcome, but following the data and
Following
not
the data.
kind of
Yeah.
building your case. Yeah,
Exactly. Exactly.
love
For
it.
instance, my dissertation project was trying to look at pandemics and how effective testing, like widespread spread testing, would be, doing a health economic analysis of how effective widespread spread testing could be for pandemics. And the data wasn't good. I was hoping that, widespread testing would be something that would be, very, very helpful for pandemics and health outcomes, but it wasn't good. And I had to report that.
Did you
But at
do
the end
that
of the day,
thesis? Did you do that dissertation before COVID-19?
I did it. So
That's hysterical.
yeah, my um master's education was in the very heart of COVID-19.
Okay.
And by then we didn't have vaccines, but we had a way to test for it. And that was
Mm.
the only kind of public health measure that countries were putting in place to curb it to the extent that they could. And I was hoping, testing would be a good measure. It just wasn't that good a measure from
Oh,
a
geez.
health economics perspective. But then, and this goes back to what we were saying, from a much wider sociopolitical context, it then becomes a good public health measure, if you see what I mean. So
Mm.
from a much wider socioeconomical, to keep, keep the societal peace, to kind of rein people in, to reduce the burden on the hospitals, then it becomes a good measure. But taking it in isolation, it's not so, it's not so robust, because it doesn't really do much for apart from social distancing and staying home, it doesn't really do much for health outcomes going forward for the person that you understand. So those are some of the subtle things and considerations but at the end of the day, we just follow the data and make recommendations based on the data.
Which is good to know, because you're looking at it specifically from an individual health outcome.
Yes.
Versus a public health emergency stemming, putting these other measures into place to stem the disease, support the hospital system. Interesting.
Exactly.
We got to turn over every rock and look at it every different way to kind of get the whole picture. Because as you're saying that, I was like, oh my gosh, I can just see the news now. Like somebody in American politics is gonna hear our podcast. Wouldn't that be a great problem to have? Hear our podcast and say, this doctor says we don't need widespread testing. Like,
no, I didn't say that.
Time out. Put this into context. Listen to the entire podcast.
You have to put it into context. You have to put all of it into context. In the wider context, it becomes, a good public health. But in narrow context of just testing as one, single, it's just like saying, if you put it in a regression model, for instance, it would be effective, but then it would be confounded by other factors in the model. And then if you took it out of the regression model and tried to, if you corrected for all the other confounders, you would find that the effect wasn't that big. But put in with other health economy or other public health measures, then it makes a big difference. That's kind of the sense where, what the data said.
Yes.
But that's what data is. You have to follow it righteously.
Yeah, very important. It's the foundation of so many decisions, data-driven decisions. I've loved our whole conversation. So many important aspects of health equity and healthcare. You've made me laugh. You've made me cry. All the spectrum.
And I'm happy.
Of emotion. We're ending on a laugh. John, it's been such a pleasure. So enlightening to understand the intersection of healthcare and economics more, and something that can be a vehicle for helping to understand that and put into context cost analysis and how we approach that, and maybe take another step forward to achieving health equity in this world.
I'm always excited to talk about healthcare and health economics and clinical medicine, and it was a very good conversation, Kelly. Thank you very much for having me.
A big thank you to Dr. John Essien for sharing his wisdom and experience with us. I'd also like to thank all those who made this podcast possible. Our wonderful production team, the George Milton Group, Winnie the Mood for our theme song, and my Teen Think Tank Project co-founder, Matthew DeSantis. Most importantly, I'd like to thank you, the listener. And hey, would you let us know you're listening? Subscribe, rate, and review this podcast, and follow us at problem_pod. For more information on today's topic, or to find out more about social justice programming for exceptional teens, please follow the Teen Think Tank Project at teen_think tank, or visit us at teenthinktankproject.com. Till next week, I'm Kelly Nagel.